Good morning, good afternoon, good evening, wherever you're joining us from. This is Digital Health on Air. My name's Aditya, one of the founders of Luma Health, and I'm here with the illustrious Dr. Stefano Bini. Dr. Bini and I have known each other for quite some time now. We met at a baseball game of all things.
You remember.
I know, I do. It was a fun game. It was a really cool event. So Dr. Bini is a well-known name in the field of orthopedics, and he's an endowed professor of clinical orthopedics at UC San Francisco. He's also the chief technology officer of the UCSF Department of Orthopedic Surgery and the founder of the Digital Orthopedics Conference in San Francisco, or DOC-SF. And today we've invited him on Digital Health on Air to talk about his perspective on pushing medicine forward, smart applications and new technologies. And, I've gotten to know Dr. Bini over the years as really just being a really lean in, forward-facing thinker. So with that illustrious, sparkled introduction, welcome to the show, Dr. Bini.
Tia, thank you so much. It's a pleasure to be here. And it's been just awesome to watch your success over the last decade or so. And it's not quite a decade, but almost.
I know. We founded the company in 2015. February 2025 will be 10 years for us. So, if you make it that far, you've done something right.
Yeah, we'll get to what that is.
I love it. So, Dr. Bini, for our audience who may not know you as well as I do, would love to hear just a couple of words in your background, what took you to orthopedics, kind of what was your interest in the first place, and how you landed in this kind of unique role as CTO at UCSF Orthopedics.
Great questions. Look, orthopedics, I got to med school, it was like definitely not medicine. Had to be some kind of interventional thing. And within that, I started looking at neurosurgery, plastics, and ortho. And orthopedics really struck me as the one place where you can make a difference very quickly. Like you fix it, it's broken, it's done. And I really gravitated to situations where I could impact change. And that's sort of been a bit of a trend line in my career. I eventually landed after a fellowship at Kaiser Permanente back in 1997. It was an extraordinary time of change for that company. Got to be part of that, integral part
Probably
of
an earlier version of the Kaiser Permanente we all know now, I imagine.
Very different. It actually, 97 was within a few days of going bankrupt.
I did not know that. What a different time.
What a different time. And at the same time, what never let a good crisis go to waste, right? And so the leadership of that at the time was Robert Pearl took on the reins, really drove this extraordinary change and took us to the top of the healthcare food chain by a decade later. It was actually relatively quick. And I got a chance to see that happen real time and I was honored to be part of that. And at the same time, the same in 1997, that was also sort of the tweener moments of the beginning of the internet. San Francisco, as you remember, was an extraordinary place to be.
Oh, yeah.
Everybody was on a high 99% occupancy rate in the city. And I, like everybody else, did a startup that lasted a couple of years. But while I was full-time orthopedic surgeon, it was kind of hard. But I got my sort of like MBA running a startup. And then after that, I went on to do sort of chief medical officer, a couple of companies. But eventually decided to get back into healthcare because this is digital. It was the internet 101, if you will, the very beginning. Digital health didn't come around till the early 2000s to 10. It was at that time like, hey, wait a minute, now it's time to look at this again. At this point, I was head of a department at Kaiser Oakland, and we I saw some opportunities. We had a problem. We had limited access to physical therapy.
Sure.
I was in joint replacement. The demand was growing through the roof as an older generation, the boomers were coming through and driving massive demand growth. And I came across a small company called Capture Proof. They had a nifty little platform. The company's still doing great. They're based in Paris now. But they had a little platform that allowed us to interface with patients asynchronously with video clips, and we leveraged it to demonstrate a 60% reduction in demand of the inpatient care paths. And that paper, which was a randomized controlled trial, so it was done pretty well, got me a lot of attention. And
a number like 60% is an unusually large number for not even for any industry, but for healthcare. That's an obscenely large number.
Obscenely large number. And as you know, we all saw huge opportunities at a time to take these nascent technologies and apply them to the real term problems that we have. or actual pain points. Like they're not just little problems. They're like, we can get people in to see physical therapists. And the success of that was great. So that got me to Health 2.0 and a bunch of the meetings, met people like Daniel Kraft. And then my time in the digital health space never really went away as I get more involved. But at this point, I'm like meeting people like you at various events and going to orthopedic conferences. I'm like, these two sets of people are not talking to each other. There's no place where you, as a CEO of a startup, could go and meet a bunch of forward-thinking orthopedic surgeons and throw in a couple of healthcare administrators into the mix and some venture capitalists and have that conversation. So from that perceived need to share data, to share information, to share points of view, was born DocCast out, the Digital Orthopedics Conference in San Francisco. But again, the need to cross-pollinate across industries. When you and I met at the baseball game, you told me the problem you're going after. I'm like, immediately recognized as a problem we needed to address at UCSF and brought you into the fold. And at that time, it wasn't easy for someone like myself to interface with someone like you and know that your solution was available.
And so just consuming digital change wasn't easy at that stage. And kind of even our journey as Luma, and your journey is running the technology scene in orthopedics.
That's exactly right. So that's sort of the genesis of where I am today.
I love it. I love it. And so, one of the things, you've been an orthopedic surgeon for a good amount of time. You've probably seen, graduating physicians you're training now and part of your academic part of your work. They're more digital native, I imagine, right? They think digitally first. I'd be curious to see how like the generation that's coming out of med schools now, coming out of their training now, versus kind of maybe when you came, like, what do you see as a difference in those digital native, digital proficiencies in those physicians?
Right. So there's two sides to that equation. One is, two implied assumptions. Okay. One is that the age of the potential surgeon is a driving force in their ability to absorb new technology, and I would argue that is probably true in part. I definitely know that younger surgeons are certainly more accepting of digital solutions for analog problems.
Well, I also kind of mean in the sense that if you're a trained physician now, you've never not used Epic. Right? First, you've never not had an EHR. And so like you came into your med school training understanding, or that was just a native part of your digital fluency.
Fair. On the other hand, I've also got people applying for fellowships because I'm still working, doing tons of surgery, who have never done a manual knee replacement.
Oh, interesting. Oh, so you see it. Okay, interesting. Yeah, talk more. It's fascinating. Yeah.
Yeah. So what it is that more than age, it's where you train that matters. So if you train in an environment that not just the hospital, but the entire community is not particularly exposed to technology, you're not going to be as facile with the idea of transition. You've been taught how to do things a certain way.
Sure.
You know that it works well. And in that community, it's accepted standard of care.
Yep.
Into the Bay Area, you're in a very, very different environment, right? So it stops being an ageist thing. It stops being an issue of age, but more like structurally, mentally, psychologically, how are you predisposed to addressing a problem? So if your experience is, I come across a problem, I solve it with analog solutions, and those solutions work, and those are accepted and they're paid for, your interest in moving beyond that is limited.
Yeah, you're doing good work, right? You're happy with the results. There's, the results that you want are happening. Not much to say past that, like keep moving forward.
And you don't even know what the alternatives are.
Fair
Whereas
enough.
if you have an opportunity to be in an environment where you've seen digital solutions and you've seen them work, when you're dealing with your own problems, you might be more open to the idea, hey, wait a minute, is there another way to do things? So that is where education comes across. That's really important that people get exposed to these things. And these days we talk a lot about large language models.
Sure. Yeah, of course.
That large language model, if it's never been exposed to a certain kind of data, it will never give you that data as an option.
Correct. The training sets have to exist to make it be productive. Yeah.
And so are our residents, our doctors, et cetera. They need to be exposed to this technology. And right now, if you go to orthopedic conferences and they say the word technology, they mean robotics.
Yeah, that's
It's
fair.
1970s, 80s technology in reality. There's nothing new. Not this, I take it back. This next 2 or 3 years, we'll see a lot of novelty, but that world hasn't changed much in a long time, 20, 30 years. But
So
that is how they're thinking.
interesting thought here. So I've always kind of felt orthopedics tends to be on the leading edge of technology adoption. And you'll say exactly like you go to an orthopedics conference, they'll think that means robotics, but you have the opportunity to have that larger vantage point, right? You think about technology, access, software, digital health. You think about it kind of as in a much wider aperture. So, what makes you think that like orthopedics tends to take this lean-in approach for new innovations?
So, as an aside, I trained in college in political science. And when you're in
Okay,
political science, you take a set of facts and explain it from different points of view, Marxist, economic, etc. So,
sure.
in this case, you can take a for-profit driven approach where it's an environment where applying new tech is relatively easy and often is paid for. So
Okay.
financial
But do you
reward.
also find that to be true in your academic scenario, in your academic setting as well?
Now we're on salary, so there's the financial infrastructure is not quite so there. And in fact, if anything, the academic scenario makes it a little bit easier to test it, but the
Huh.
large hospital system makes it harder to adopt. So
Oh,
academics
interesting.
are great places to go try something, but then if you want that new idea that you just wrote 3 papers on to actually be bought by the CFO and made accessible to the entire system, it's tricky.
Mm.
But that goes back to understanding how healthcare works and why it is that the cycles are so long and
And kind of how probably the incentive structures line up too, right?
incentive structures. The other part of it is that, so another way to look at it is that the world of orthopedics is unique. It's musculoskeletal care in general. And the reason why I do a whole conference around it is that, look, these are short cycle times, right? So if you need an answer, you know pretty quickly.
Mm.
There's something you know within a few months, usually whether or not it worked. Secondly, we're we're centralized. There is an orthopedic surgeon in every corner, and so as a result, the care gets funneled to one area, so the volume is high. So you have high volume, short cycle times, and good compensation. It's a perfect place to innovate.
To innovate, yeah. It sounds like, I mean, also kind of feels a little bit like kind of your thesis for the Doc SF conference, right? You talked about this a little bit at the beginning, put venture capitalists, technologists, physicians, and everyone on and cross-pollinate. Like you've probably seen some of the benefits from this cross-pollination because you have these fast cycle times, these center of innovations. Like, talk to me a little bit about what you've seen come out of Doc SF.
Oh, Doc SF. If I had you guys presented Doc SF six
We
years
did,
ago.
I think, coming up on probably 6 years ago now.
Yep. And and in fact, I have to do this. If we look at all the companies that we have selected to, because there is a selection process to be shown at the conference, and look how many of them have either exited or gone on to multiple funding rounds, we'd be doing better than the vast majority of venture capitalists.
Maybe you just
So
want to reframe it as an accelerator at this point.
that's a really, you know what? I'm going to write that down. Because by placing these startups in front of an ecosystem, not just a subset of venture capitalists or perhaps a couple of hospital administrators, we have everybody there. What happens is you have the presentation, but then afterwards you have these conversations, and those conversations are all informed by the information that's put out.
Mm-hmm.
So it's what happens at the breaks that creates the magic, creates the glue, creates the connections, the network effect that occurs when you bring in people from these different parts of healthcare. And then the questions that are asked on stage are also usually have a different flavor than the ones you're accustomed to, right? It's not necessarily about market size or how you cap tables are distributed or whatever. It's really gets down to okay, there are I'm going to put a bunch of doctors on stage with you, along with the technology. Let's see what questions they ask. Because you may not have thought about this particular problem, or certainly not looked at a problem from that point of view.
So it's almost semi-Socratic, right? With the question and answer actually leading to what the real value is.
There you go.
So what you just, I think the event just happened this year. You probably, there's a lot of AI, a lot of robotics. Anything that pop out at you from this go around of the cycle?
Yeah, now look, the conversational robotics was phenomenal because my idea of robotics is that the current robotic platforms are very dated. And so what I did is I brought in the former vice president of robotics at Google, Hans-Peter Bronmo, to come in and just give us, okay, talk about where everybody else in robotics is, whether they're the OpenAI with Figure 1 and 2, etc. They're creating these robots, these humanoid robots tied to large language models that can interface with humans. That future needs to meet the present.
Mm.
And we wanted to get people thinking about what the possibilities are when we upgrade the robotic platforms that are currently being used in healthcare. Will it happen quickly? Probably not, because of all the requirements around robots and surgery. But
Sure.
there's this misunderstanding, as there isn't so much of AI applied to healthcare, that we necessarily have to go to an R2D2 model.
Yeah, yeah. You don't need humanoid C3PO yet, right? There's a lot before that.
Well, no, so there's a lot of places where robots can be helpful, where in the operating room, in the clinic setting, and we're seeing them run around delivering coffee in hospitals. It's but particularly in pharmacy, super useful. So, but until you know what you don't know, you can't ask the question, oh, let me be curious about this. Can you bring this technology to my world? What would that look like? And so that was what
you're saying here. There's almost like this gap between, the vision is very, very broad, like, that R2D2 C3PO kind of version. And then there's a current like robotics platforms, which are like healthcare approved in air quotes, if you will. So kind of what you're articulating is how do we bridge that gap in order to we don't need the C3POs, the R2D2s, but we need a big step up to get somewhere in the middle. Is that kind of what you're aiming towards, or at least sort of what you're trying to articulate?
I think you said it correctly. It's not that we don't need the R2, the 3PO. We may 3PO. We may, but
I mean, at some point as T approaches infinity, yeah.
The question is, if super smart people don't know that these technologies exist because they're just not exposed to them in their daily life, or they don't think of them as being accessible, then they're not going to start dreaming, asking the question, pushing the boundaries, making investments. So to me, it's about leveraging. I see very much my role as exposing people that need to know this technology to the technologists themselves. So doctors, for the most part, have people like yourself up on stage who know your business super well, inside and out, have ideated, and to make that vision accessible to people who might be able to use it if they only knew about it. And so I bring the doctors in, I bring the hospitals in, and then I put guys like you up on stage. And to me, there's not much value to putting doctors up on stage speaking because they're not the ones driving the change. So that's what makes it hard to bring people there. But once they're there, they walk away going, oh my God, you changed my worldview. And that is really how we thrive, by getting those.
I think there's something funny you said, and I chuckled at it because it was funny because doctors aren't leading the change, but you clearly are a doctor who is leading the change. And I think about that, and you've done it in this world of orthopedics, for lots of reasons you articulated why it's a perfect petri dish for innovation, right? Yes. Where else, in your mind, if you think outside to healthcare writ large, where else are those centers of innovation? Where could they exist? What have you learned? Where else? What other specialties, if you will, should be thinking like this?
Okay, I have two ways to answer that question. Let me take the first one. I just came back from a 6-month sabbatical. I traveled around the world. Yeah, thank you. I traveled around the world. And I had meetings set up with all these people driving digital health innovation, literally from New Zealand to India to Middle East to pretty much every country in Europe. 25 countries, about 40 interviews, which will eventually come out in a podcast. I'll start working on that later today, by the way. And giving me this global view of innovation. And I tell you, the one thing that if somebody ever tells me again, it cannot be done, I'll tell them, no. Don't tell me it can't be done. Tell me you can't do it. I'll believe you. But don't tell me it can be done, because I've seen people do insane things with either no resources, which is one way to look at impossibility, or the other under massive restrictions, like in Europe, where it's super hard to get anything done just because the government doesn't let you. And yet people work in that system, making crazy things happen. So to me, the innovation writ large is alive and well. What's happening is these technologies are broad horizontals.
Yeah, sure.
Not verticals. So you can't say, oh, robotics is only good, is what else? It's not it's a, your question was, where else in healthcare can we see innovation? The answer is everywhere.
Yep,
But the
I believe it.
technology that you're going to leverage is more specific to the problem you're trying to solve, right? Now, you're going to
Makes sense.
have some contexts where that application is easier to sort of understand. How it might work, it has to do with the amount of integration within the electronic ecosystem that your particular technology is at. But it is, boy, remarkable what you can do with text messaging, like in India. It's remarkable what you can do when you have everybody on a digital platform, like in Denmark, like their entire health record, every single person is on the web. So it's remarkable how you, depending on the context you're in, you identify the problem or the pain point, I should say, because problems never get solved, but pain points do. And then you say, okay, given this pain point, what are the best technologies to solve it? Which ones are mature enough for us to actually leverage without worrying about X company failing? And then you just do it. But then you have to have the backing of the organization.
So let's maybe close out with one very specific question, kind of using the vision you painted, your 40 interviews that you've done over the last 6 months. On sounds like it didn't sound like you went on a sabbatical, by the way, Dr. Bini. It sounds like you went on a work trip. So like, call it a sabbatical if you will. I'm not so sure. But what's the one problem you've seen in healthcare that you kind of wish could be solved? AI, robotics, general access. Like, what do you see that needs solving still?
So AI and robotics are tools. They're not problems that need to be solved. They're problems, they're tools for a given solution. I don't, without sounding, it's going to be trite because the big problems are all going to be trite. Well, it's going to be funding or data interoperability. But I actually think that if we could put one thing at the top of the list, I'd probably put alignment with government initiatives. I'll tell you why.
Well, this is an interesting take. Okay.
The healthcare is between 1/5 or 1/10 of most countries' economies. Mm-hmm. It's ridiculous to think the government should have no role in it.
Fair.
Yes. Fair? Okay. The problem is for a lot of the technology, when you let the free market solve for a problem, it will always solve for profit.
Okay.
The government, most governments will solve the equation for the patient by putting in place appropriate regulations, appropriate backing, appropriate safety regulations, etc. Especially now, this AI thing. We all want to move fast, but I agree with those that are sounding a little bit of alarm bells and saying we have to slow this particular train down until we got our hands around it. And yes, it's moving slowly. But for example, the EU may take its time on everything, but by the time they're done in the next couple of years, they'll have a pretty decent infrastructure within which to play. And they build the data infrastructure now that people can collectively access. They got other issues. The United States doesn't have a single, the government has them. No, I'll skip that part. It gets to be complicated. But my point is, if we can somehow stop saying the government is our enemy and saying our government is our friend, how can we leverage the tools of government to support innovation? And I think we'll be in a better place. I think all of us will be in a better place.
That's a really, really interesting take. And I think you see it from a regulatory framework from the broader, from the EU and the broader tech industry around, the 2000s around the browser and the 2010s around the app stores and the 2020s around, embeddable mobile platforms. You'll see that, unlocking big changes in innovation do require the intervention between the taxpayer, which is represented by the government, and the public writ large. And I think that's an incredibly interesting thought for us to wrap up this episode of Digital Health on Air. I'm very, very thankful for your time, Dr. Bini. I think your insights and your story are just valuable, insightful, and super interesting. And honestly, every time we get a chance to get together, I learn something. So I'll take that as a win personally.
Thank you very much. Pleasure to be here and excited to continue to watch Luma grow and expand into new and better things. I love what you're doing.
Thanks so much, Dr. Bini. See you all in the next episode.